Jeff Olick, MobilityWOD 102, superstar. We've got this stuff going on. What we want to do today, Jeff's in town, we want to talk about one of the ways that we sort of sort through problems. What we tend to do is believe we don't know how much capacity can be gained in this tissue system. We don't know. Right? Have you worked on this ankle before?
Almost 30 years.
Okay, so we have 30-year injury. You move well, you limit your compensation. We can cross a lot of that off the goal. Like, you're not working around the problem and causing more problems. So we have spent hours and hours and hours together working on that. So the question now is there anything else that we can improve? Right, so as we work through our systems thinking, we're trying to cross things out. Can we improve sliding surfaces? Is there a joint capsule that could be improved? Right, because you've got the software, and now you're just running on an Atari 64. That's the problem. You've got this big engine upstream, obviously. He's handsome, he's got hair. So now the question is, can we improve that? So that's what we thought we'd do today. And anything that we can do manually today, because we know it's not just a nervous system issue, otherwise you would have unlocked it right now. Right? Yeah. You just need to do it more. You gotta want it more, man.
You gotta want it more.
And sometimes it's just mechanical. And what we want to do is say, hey, are there things that we can do to improve? We'll find out. We don't know. I've never touched your ankle, but we thought we'd just take a swing at it because sometimes it helps to have an outside set of eyes, right?
Right.
Okay, so in your own words, what happened to your ankle and what's going on? What do you want to do?
I was 13 years old, playing in a high-level football game. First snap of the game, forced fumble, playing nose guard.
You ever told this story before?
Once or twice. And broke my ankle. At the growth plate, 13 years old, rushed to the hospital. Doctor in the ER said this is gonna hurt, and went, oh, and put it back. Saw another doctor, a couple days later, and he says, no, you're good, we don't need to have surgery. I was in a full 8 cast for about 8 weeks. 13 years old, being wheeled around by my sister.
How was that? Is that the worst part?
That was fun. Got to ride the elevator up and down. Lost the elevator key in the shaft.
How old are you now?
I am now 40 years old.
Okay. So, have you had surgery on this ankle?
Never.
When you go in and ask someone about it, what do they say about your ankle?
X-rays say my ankle's fine, yet it goes off to the right. So we're not really sure, tibial torsion, don't know what's going on. But I can't get full dorsal flexion and it goes off to the right. I can't ski, can't ice skate, can't rollerblade, can't do anything where I have 2 feet going straight. Overcompensate running, changes the shape of my calf, changes the shape of my hamstring, everything.
All right, perfect. It's what we call old and cold. We don't know. Let's find out. I've seen you move. Tell it, kick that shoe off for us real quick. Kick that one off too, let's see it. Walk around in flat shoes, making your feet strong. That's not an issue. Show us what it looks like when you squat. Any stance, whatever you want. So go as deep as you can without that foot coming on the other off the ground. Or squat as deep as where you feel you start to compensate. So you definitely block there. Stand back all the way up. Go a little bit wider. And this time, squat as deep as you can without letting that foot get squirrely. No, put it where you need to. Right? And then, so ankle's not collapsed, arch isn't collapsed. Let me see you squat, but this time, when you feel like your pressure changes through your foot, stop. So if that's shallow, that's fine.
Keep going all the way down.
Okay, so that's we have a good reference position. And if you shove your right knee out a little more, up, stand up a little higher, put your heel on the ground. There you go. So there's a good position. So we see a reference between, if you feel like you're having a hard time getting that knee coming out past the toe more than that.
Well, not only that, but I can't even put my foot there. If you look, my knee then tracks internally.
Going around, it collapses. Okay, so let's see what's going on. So now we have a baseline. Just for the grids, show us what knee to wall looks like. How far can you go? Okay, so you're off there. So come back forward a little bit. Find a place where you keep your heel on the ground. Pressure your heel. No pressure on the heel. Come closer. Don't let your heel come off the ground. Go back a centimeter more. Heel on the ground. Oh, you lost your heel there, yeah?
Barely, yeah.
Okay, so we're roughly there.
And then this one.
Let me go back in there again. All right, so we have a reference there. Okay. Let's see what the other foot looks like in that same shape. Ooh, that's tough, huh? So put that foot to the wall. Can you can touch it there? Back it up a little bit. Back it up a little bit. Don't let that. Okay, so we got a little test-retest feeling. Okay, so first thing I want to do is I just want to see what this feels like. So let me have it on your stomach here. So we've cleared out some questions, right? We know that this was an old injury, but night sweats, dizziness, fever, vomiting, nausea, unaccountable for weight loss, weight gain, changes in bladder bowel function are
Negative.
negative, right? Numbness and tingling in the foot, any other strange thing. Are you angry about your father and that's why you won't flex your ankle? No, okay. So it's just old and mechanical, right? So we're gonna just feel what that looks like and feels like. Okay, so we're about 0 dorsiflexion there. On this side, it feels a little bit easier through. This is your affected side, correct? Okay. So on his non-affected side, or less affected, because they're both affected, that's the correct term. Not good and bad. So we have more implicated, less implicated, right? This leg has to do a lot of work. So in subtalar neutral, he's easily past 90. And what we can see is in this shape, I can press him, and when I overpress him, I get a little bit more, but you know, we have a stiff athlete, but at least he's past 90 on this side. We can see that. And again, all I'm doing is putting that ankle in that neutral position. So if he was standing on our 27 squats, his foot would be in this neutral shape, and I'm just keeping him in that shape. And then what I'm feeling like is, does that feel like a bony block there? And when I press, it just feels springy. It just feels stiff and springy, but springy. Is that what it feels like to you, Jeff? Okay. So we come onto this side, put him into this position. The first thing I notice, it is difficult to get him to get that foot straight. So when I try to get that foot straight, I'm already up against tissue restriction. So if I put him at the limits of just normal tissue restriction, I start to grab a lot in the tibia, as you were saying. So as I start to wind that foot straight, what's happening is I'm experiencing or seeing he's getting a lot of motion starting to happen at the knee capsule, which would make sense because he's had 20-some years to develop bony growth, rotation, capsular dysfunction around the stiffness in this ankle. So if I put him into subtalar neutral with this foot relatively straight, notice he's not that far off from his other side, right? He's actually positive dorsiflexion, which is sort of a miracle. But also, in this position, when I overpress, it still feels springy, which tells me I don't have a bony block here. So if I ever am pushing on something and it feels like I'm running into a wall, that tells me it may be a wall, but it's a bone wall. But this still feels springy all the way through. Is that what that feels like to you?
Yeah.
Okay. Did that cause any pain or symptoms or any other thing when I pressed over there? What I should have said is, how does that feel? It's fine, Kel. All right. So what I want to see now is, can we improve any aspect of this joint system? And one of the things we're going to look at is, the first thing that I'm going to check on him is we're looking at, hey, do we have skin that doesn't slide? And here we do have a lot of skin that doesn't slide. So if you check any aspect of your body, you should see that your skin slides over your bones. Any bone, it slides. And in this situation, it should slide over the tendon, but it does not. So you can see how I can grab his skin like a Shar-Pei down here, and then around the tendon here, it becomes very, very stiff. There's only a word for that. Like it's sticky or stiff. I don't know if there's a word like, I don't want to adhere to this old language, but I noticed that you have some skin here that doesn't slide. So first order of business, we're going to see if we can improve some simple superficial sliding surfaces. So I'm going to grab a little crossbow, hang on. I'm seeing if I can free up some of the skin. If he's got ostensibly some really superficial fascia that's sticky or not sliding, this represents a problem. And the language we use comes from Gil Hedley. And if you haven't been to Gil Hedley, check him out. But Gil Hedley's anatomy thinking is he describes how these surfaces are supposed to articulate as sliding surfaces. And that's an easy kind of catch-all. So what I'm going to do here is I'm going to take this ball, I'm taking him at end range, and this is what technically is called fascial release with percussion, and I'm just seeing if I can get some movement in the slack there in the tissue. So I'm just grabbing, pulling down, and just giving it a whack. And what I'm trying to do is get this impulse. And the first person who ever did this was a physical therapist, where I became aware was Greg Johnson out of Colorado. So if you want to look up more of this, that is the original, and he has a bunch of tools, and it just turned out the lacrosse ball worked really well for us. This lacrosse ball has just enough tack. Notice that I'm starting to get a little bit more motion. So I'm not coming in, I'm just taking up the slack, coming down. The only person maybe I wouldn't do this to is someone who had hemophilia, or if I had an older person who was prone to skin rips. How does this feel to you?
Feels fantastic.
I love it. Keep doing it.
Yeah.
It doesn't feel good. So all I'm doing is just finding these little planes, take the slack out, and then seeing if I can just restore that motion in the system. So here around the ankle, notice that it's very sticky. Slides side to side, but not up and down. So you grab that skin and just free it up from the underlying surfaces. And look what happens. We come on the inside, do the same thing here. It's like he's got wearing a glove that's 2 sizes too small, Johnny Cochran style.
OJ.
For the foot. So it feels like his fascial glove is really stiff around the ankle. So now what we're going to see is I've gotten a little bit more motion through this sleeve, and you can see as I pull on this, look where I pull. It pulls all the way down into the calf. So this skin, you're not flexing, are you? This skin is so restricted that you can see how it's implicating the entire fascial kinetic chain, fascial system. This osteofascial connection shouldn't be tacked down. But look what's happening. So if I have a restriction in that fascial chain, it can impact the skin through the entire system. Ideally, I shouldn't be drawing this whole sheath up and down around the function of the calf just by implicating 1 centimeter of glide at the ankle. That's really strange and doesn't happen to me at all. These systems happen independently. So my skin should slide and it shouldn't yank the whole calf all the way up the foot. And look how tacked down and connected that is. For what a reason. Look, I'm all the way down in his foot here, and I'm still yanking on the skin all the way up at his knee and actually through the hamstring. This is actually the coolest thing I've ever seen. That's some weird ass action there. Okay. That's all well and good, but does it change anything? So let's find out. One thing is that your foot is really warm right now. I don't know if you notice the difference that it is hot. So as I flex that, holy moly. Does that feel any different to you? That feels massively different to me in terms of the range of motion that I'm able to get and the ease with which I'm able to get there, right? So does that feel any different to you?
Yeah.
Let me watch this. How does this feel now?
Better.
Okay.
Is it going straight? I can't tell.
Well, let's find out. Stand up and put that thing under some load. Remember, what we're trying to do here is just create a hypothesis, test our hypothesis, as we work through our, so we'll just walk on it first. Don't even, just go walk, see if it's better, same words.
Yeah.
Way better.
In what way?
It's not pulling, right?
Oh, okay.
Like as you said, it can pull from here all the way up my leg. I can.
Look at that beautiful torsion. That looks a little better to me. I can't, I'm not a doctor or anything. Let's go ahead and come over here and measure what that feels like. So we have your normal foot. So line that foot up with the normal foot piece, right? And then just go flex there. Okay, so we're starting to come off the ground. Okay.
Better,
Yeah, that's definitely better. All right, on your stomach again. And all we're looking at is, does this tissue slide? Is he independent? And this can be done by just freeing up how this tissue is moving. The second thing I want to look at, and we teach ball whacking, it's even in all the supple leopard. The second thing we want to look at is, does this fibular head glide the way it's supposed to? So when he flexes his ankle, this fibular head should glide backwards and this direction a little bit. And that's when we put a ball here and do that mobilization. What we're trying to do is get that fibular head to glide backwards. So this is another self-treatment that we teach. I'm just going to use my shirt. It just gives me a little bit better grip sometimes. TheraBand. So let me show you what I'm doing. I'm just grabbing here, and I'm just trying to get this glide happen, and it feels like it moves, but it's so stiff. Do you feel how stiff that is? So as I'm pressing his ankle into dorsiflexion, I'm gliding that backwards into this angle using the heel of my hand, which is the same mobilization we did with Jill Miller. We've done this many times with a yoga tune-up ball, with a regular ball here, just trying to restore that glide. And then Jeff's going to start joining me and start pulling his foot down as I push. So I'm giving him a little cue for overpressure, and simultaneously I'm gliding this joint backwards. The first thing I did was notice that we created some slack for it by freeing up the fascia through the skin, right? Then we're just seeing if, hey, does that allow for better function at that talocrural joint? Or that, talofibular joint. The bottom part of where the fibula is coming into the ankle. So we're just gliding this backwards. Again, we're not trying to show you 100% of every physical therapy intervention. We're trying to show you how we work on systems and can we improve function in a really old and cold athlete, because we don't know what's possible for Jeff. Our hypothesis is that there's capacity to be gained in his range of motion and his abilities to move freely. Can we give him 5% back? Did you see something just changed? And now it's not stiff, and all of a sudden it started moving again. So now I'm really pressing a lot further into end range. He's helping me, so I'm getting his nervous system working, and I'm just gliding over and over again, coming out, gliding, coming out. Same thing you would do in the mobilization. Now, a couple things that we're looking at. One is, do you feel the difference in the torsion here? I can get the foot straight pretty effortlessly. Before, I was pushing into a lot of resistance here. Do you remember that? And now, look at how this just rotates. Almost like if the fibula is stuck here, it's also stuck at the knee. And all of a sudden, wow, maybe we have the opportunity to get that foot straighter. And then as we check his dorsiflexion here, you can see once again, we're easily pressing in to this end range, and we've improved his dorsiflexion significantly. But that doesn't matter. What matters? How does it feel? Let's see. Prove it to me. Prove it! Passive range of motion means nothing. So this test-retest is nice. Gives him a reference. That's definitely getting better. Yeah. Go ahead and walk that out and squat it out. Tell me if you notice the difference. Ida Rolf once said, if something's not in the right place, get in the right place. If something's not moving, get it moving. What's the goal? Motion. What's the goal? Returning his indigenous and native motion. Do his little squat test, which is a big tell. What do you think? Better, same, worse?
It's better. It always feels like there's a block, right?
Okay.
Right there. That's
So-
what it feels like. I'm hitting a wall.
Yeah, so go ahead and squat to the depth where you don't start to compensate. So already your feet are way straight. Oh, that's great. And just squat to that, and you start to collapse there. Shove that right knee out a little more. There you go. Now push into that. I know a lot of people who haven't had traumatic ankle injuries who can squat that deep, they'd be happy. They play in the NFL now. All right, so now let's see if we can take a look at how that calcaneus is moving. Put me on your stomach again. So one of the other mobilizations that we do is we look at how well the calcaneus everts and inverts. So in dorsiflexion, he should be able to have some motion into this joint. And what you're seeing is that what I'm doing is moving the fat pad. I'm not really moving the joint here. So this joint feels like it's, I don't know, what's the word, stuck. Just, can you feel that? So on this ankle, in dorsiflexion, I have a little bit of motion in the actual joint itself. Again, his fat pad is moving, but here I still have some, even at end range, I've still got a little bit of wiggle room. And what you'd see is in the bottom position of the squat, can I collapse my feet, can I pick them up? And if I'm stuck, then I only have one position. And what ends up happening is when that ankle gets stuck, the implication is that I'll never be able to unimpinge and move through. It's like, as Coach Sean on MobilityWOD says, you can think about your ankle like a tumbler, and if I have to line up all the tumblers in order to get the key in, and if you're out of position because the ankle collapses, then all of a sudden you have a block. It's like trying to walk through a doorway and keep walking into the wall a little bit. So we throw in this mobilization where we free up the calcaneus a little bit. Flip on your side for me. Your job is to keep this knee down. Hold that knee down here. And what I'm going to do is try to free up his calcaneus here. I'm going to see if I can get some motion into his calcaneus. So if he does this himself, he sits up on the edge and just pushes end range dorsiflexion and pushes, and that's what that mobilization looks like that we do. But I'm going to try to do it this time. So I'm using my shirt. Gives me a little grip. He's holding his knee down. I've got him into end range. What I'm going to do here is I'm just going to free up and see if I can get any motion into this joint capsule here. And if you can think about how much you weigh, 220?
Yeah.
You think the chances of me snapping this off are great? No. Besides, I'm a therapist licensed in the state of California. But what we do is teach everyone how to do this themselves. So all I'm trying to do is just get a little motion straight down this direction into this calcaneus in this position of emphasis, and which also happens to be its position of restriction. So I'm biasing the ankle up so that the knee would track his little toe, and I keep that ankle engaged in a good position, right? So foot down, you can imagine that the knee is tracking this toe and his foot is out. Now his foot is straight and his knee is out. Now we're trying to see if we can get some motion into this calcaneus. If I was going to write this in my note, I would write this as stiffness is focus, which is abbreviated for SAF. Stiffness as
Focus.
And sometimes athletes just get stiff. That's what happens. What we're trying to do, restore their motion so they can do what? Move again. We can restore that indigenous range. That's the key. All our mobilizations are what we call position transfer exercises. If you see a therapist, they're mobilizing you so you can do what? Get into the shapes that are required by the human body. So I'm just hanging out here, get a little motion into this joint. It's a Brian McKenzie sighting. Getting some movement in this ankle. Notice how long, people say how long do we mobilize? We say we stay on a joint, or stay on a tissue system until we make change, until we stop making change. So what I'm trying to do is just get a little bit of motion in here, and now it's starting to free up a little bit, until I make change, until I stop making change. And if I was a therapist, I would have done, true therapist, I would have done 30 seconds and reassessed, but I know it's stiff. We're trying to show you and translate our clinical thinking into how we program on MobilityWOD. That's what we're trying to do here. My brother, walk that up. You're gonna feel drunk, that's okay. Whose ankle is that? Demon's out! But look at that motion you have in the joint there, that was great. Let's test and see if it improved your dorsiflexion. I'm just using that compared to the other side. Damn, son! It's all in your brain. Yeah, it's all neurological. Now what I want to do, I'm going to have you on this side, so sit at the edge of the table here. This is the foot we're working on? Okay. Lay down. Slide it a little towards me. Good. You can bend this leg up if you want. What I'm going to do here is I want to see if I can get into the joint capsule. So if you've seen our classic banded mobilization, We took a Mulligan idea, applied it to a Maitland mobilization. We like it because it's weight bearing. So when we're using the band below the stirrup of the tibia and fibula here, and we're trying to glide the foot backwards on the shin, or on the shank, what we're doing is we're putting the band here. This is where people get confused. They're putting the band here. We're always advocating for this. There's a popular mobilization app that actually has the band in the wrong place. You can figure that out for yourself. The idea here, though, is that I'm going to dorsiflex him, but not let him collapse. So I'm keeping him in a stable shape. And this is what we talk about on the site and in the mobs, is that we don't want, let me scoot back just a little bit more. We don't want him, you don't have to control anything, you'll have to control your foot, to collapse as we mobilize. So what I'm doing is taking him to end range here, and I'm trying to fulcrum off my fingers to create some gap there to see if I can glide this from this anterior to posterior side. There's a therapist from Kaiser named Steve Schmidt. He is one of the head therapists at Kaiser Vallejo. Shout out to Steve Schmidt. You look him up, genius in pain science, lecturer extraordinaire, one of the greatest best therapists I've ever seen ever, Steve Schmidt. When I was a young physio, he blew my mind all the time as a student. So I'm just trying to load him up in dorsiflexion and then find this corner of his capsule, which feels restricted. And when Jeff and I were hanging out in Gig Harbor at a level 2 course recently, I said sometimes it's nice to have a 230 kilo therapist working with me.
230 keys?
Well, you know, same stuff.
Big dude.
107. 105 is 230, but I don't weigh 230. 107.
Okay, yeah.
I don't know if I'm 107.
You're in the new 109 weight class.
I'm in the 106 weight class. 106. Is that what it is? Not 107, it's 109? Dylan Cooper 109?
Dylan Cooper 109.
Oh, I thought it was 107. Wow. That's a big jump. It's a lot more muscle you can put on.
Fact check.
Fact check.
Yep.
Dylan Cooper 109. Fuck that out. Woo! It's hard work for me, son. Got my sweat on. What do you do for workout?
Work on ankles. Look at that.
Wait, what happened?
My knee's straight.
Stop it! Stop! I didn't work on your knee.
I know.
So in this situation, we're assessing him to try to be feet straight, right? But he's going to be powerful all the way out to 15 degrees. So he can turn his feet out, squat. In fact, absolutely we're going to have him work in those planes. Remember what he said is that, hey, I have a hard time with skiing, I have a hard time with skating because I can't get the foot straight.
Can't get it straight at all.
Right, so we're not just talking about general physical preparedness or even sports preparation. We're just saying, hey, can we squat here? And that looks a little bit better. Let's go ahead and turn your feet out even a little bit more. Let's give you some range. And don't collapse the arch. And now let's see how deep we can go into that position. Keeping the heels on the ground. And this would be a position, obviously, where we say, hey, get some Olympic lifting shoes. Let's give you some space so we can get your heels up. What we're trying to do is give him access to the best mechanics and the best tissue physiology available to him based on his unique self. Now, here's the deal. We've been banging on you for a while. We've made a lot of change. And because he doesn't live locally, I'm over treating him because I want to get some change done. So just caveat, might you be sore tomorrow?
Yes.
Would that be okay?
Yes.
Yes, count on it. And especially as that tissue's come back online, he's going to have to change how those fascias are pulling, how the musculature is having a relationship with his ankle. There's just a lot of intervention that has to go on here. But the idea is better, same, or worse. Is it better, same, or worse?
It's better.
So we would keep, what I was taught was that we would keep, he didn't do anything, didn't have a mobilization plan, which you do, didn't squat and exercise, which you do, I'd keep at least 50%, or expect to keep 50% of my changes between visits, right? But this isn't just temporary neurologic change. Have we touched your calf muscle?
No.
No. We've gone after skin and joints. Joint capsules, and I think that's what oftentimes gets lost in this narrative around self-care is what's going on with the fascial and these osteofascial connections, and then where fascia and connective tissue meeting bone, and what's happening with the joint capsule. I'm not going to waste his time trying to mobilize his calf. I mean, I'm sure I could step on his calves and get a little more, but he can do that himself, and is an MobilityWOD practitioner. So that's how we think about that. All of the things we did, we teach you how to do MobilityWOD. Sometimes you take all the slack out yourself and say, I need some help.